Kia ora koutou and welcome to tonight's Goodfellow webinar. This session is supported by an unrestricted educational grant from Roche, and the content is produced by the Goodfellow Unit with support from our subject expert. Tonight, we will be discussing emerging treatments and management plans for our patients with congestive heart failure. My name is Pulasti, and I will be your facilitator for tonight, and I have the pleasure of introducing our speaker, Dr. Gerry Devlin. Gerry is an experienced general cardiologist with a special interest in the prevention and management of coronary artery disease, hypertension, and heart failure. Gerry is the current medical director of the Heart Foundation and the clinical leader of the New Zealand Cardiac Network. So without further ado, I'll pass over to Gerry.
Lovely. Thanks very much for the kind words and introduction. So what I'd like to do in the next 30-40 minutes or so to leave plenty of time for questions. I find this a more challenging, we're just talking about before we start, a challenging environment because I like interaction when I usually present. But what I'm going to do is talk, my title, as you can see, is Can We Make New Zealand Stronger? And I'm going to concentrate on heart failure, reduced ejection fractions, challenges and opportunities. We'll share some background with you as to why this is important in New Zealand, some new data you may not be aware of. And I'm going to try to make it a case-based discussion as well. So we'll see how we go. So heart failure affects a large number of people in New Zealand. To 2023 data estimates a prevalence of 121,000 people in New Zealand. Now that's from the health survey, and that's jumped up quite a bit from the last data that I was aware of about 5 years ago, which was around 70,000 people. So that might reflect some different ways of which, better awareness of heart failure and people living longer with heart failure. But some data from 2021, 2022, just over 12,000 hospital discharge for heart failure, with still an average length of stay of just under 10 days. So people stay in hospital for a long time when they present with acute decompensated heart failure. 1 in 3 people with heart failure reduced ejection fraction are no longer with us at 3 years post-diagnosis. Hospitalization with heart failure increases mortality by 6-fold. And patients interact with primary care an average about a dozen times a year, and 3 of these consultations relate specifically to heart failure. So there's opportunities for actually trying to alter the course of heart failure. Again, some recent data from the Ministry of Health website, looking at adults diagnosed with heart failure. We know that the burden of heart failure falls unequally on our Māori population, with 4% in males, about just over 3% in females. We also know that heart failure tends to present in Māori Pacifica about 10 years earlier than Europeans, for reasons that we're not fully aware of in New Zealand. So right on to a case now. This is Tony's a 74-year-old man, dating back to April 23 when I caught up with him, having been in hospital recently with an acute decompensated heart failure admission. As you can see, he's got a extensive cardiac background with diagnosed ischemic heart disease with previous PCI in 2012. He presented in December 2022 with an acute inferior infarct for which he received successful thrombolysis with subsequent PCI done in Waikato. And he had no symptoms currently suggestive of angina. He also has a past history of paroxysmal atrial fibrillation with previous AV node ablation and pacemaker in situ with mild renal impairment, CKD stage 3A. So when I saw him, he was complaining of effort intolerance and fatigue, and this was in April. He'd been in hospital about a month previously. He had no evidence of congestion. His blood pressure is as shown, 116/80, with no significant drop with change in posture. Heart rate 70 regular. Remember, he's got a device in situ. His natriuretic peptide was elevated at 600 picomoles, and that's the NT-proBNP at 600 picomoles per liter. And he had a recent echo that showed severe LV systolic dysfunction with previous mild to moderate LV systolic dysfunction. His medications are as listed here. When he was in hospital, he was switched from an ARB to sacubitril/valsartan. The dose is shown there, 50 milligrams BD, so low dose. He's on a little bit of diuretic for symptoms of congestion and a small dose of bisoprolol and rivaroxaban to reduce thromboembolic risk. So I think it's important to go back as when we see someone with heart failure, where do we actually begin? I think three things, and this applies to other conditions as well, other cardiovascular conditions and other health conditions, really. We want to firstly make people feel better. So that should be number one, not number two, morbidity. If we don't make people feel better, then they are less likely to engage in treatment that's going to improve their prognosis if they're not actually feeling better. And ideally, we want to prevent progression of disease as well. So ongoing myocardial damage, make sure we're dealing with things like left ventricular hypertrophy, managing blood pressure well, all the things that we should be doing, lipids, etc., to minimize the chances of disease progression. But we want to firstly make our patients feel better with the aim of keeping them well in the community. So this is an interesting paper. I'll just digress slightly. This is around the use of loop diuretics. This is from the group in Glasgow. They looked at over, I think it's over just under 200,000 people in a population of 1.1 million in Greater Glasgow and Clyde, 200,000 people with cardiovascular disease. And what they found is that loop diuretic use, either in the presence or absence of a diagnosis of heart failure, remember in a population with cardiovascular disease, was associated with worse outcomes. So if you look over here, if you were using a loop diuretic and you had an established diagnosis of heart failure, you had a significant hazard ratio of 2.1. If you looked at loop diuretic alone, so some of these patients may well have had other cardiovascular conditions that warranted diuretic use or other comorbidities that warranted diuretic use. Hazard ratio wasn't much less at 1.8. But if you look at heart failure alone without the use of diuretic, the hazard ratio was only 1.2, suggesting there's something else that we're doing with that group other than loop diuretic use that may be impacting favorably on longer-term outcomes. Having said that, congestion remains in many, many patients with acute heart failure admissions at discharge. So patients they come in because of symptoms of congestion, and about 1 in 3 patients are discharged with ongoing symptoms of congestion. And it is a concern that certainly in restrained health systems such as our own, that we are more likely to send people home early today, and that we may be sending people home with ongoing symptoms of congestion. Again, continuing a theme, intensification of diuretic therapy alone is associated with poor outcomes. And this is from the Paradigm Heart Failure trial, where if you look over here, intensification of diuretic therapy was associated with the same risk as representing to the emergency department with symptomatic heart failure, leading to heart failure hospitalizations. So again, emphasizing we've got to do more than just diuretics. We also know that if we get on and implement heart failure therapies of prognostic benefit, they impact significantly on symptoms of congestion. So again, a direct positive relationship with heart failure therapies and decongestion, as shown in this graph here. So what are the therapies of prognostic benefit? These are well known to all of us. This is from the ESC guidelines in 2021, and this is specifically looking at the management of heart failure in patients with NYHA class 2 to 4 symptoms with reduced ejection fraction, defined as an ejection fraction less than 40%. We've got level 1A evidence for ACE inhibitors, ARBs. We've got level 1 evidence for beta blockers. with a reduction in hospitalizations and death. We've now got level 1A evidence for mineralocorticoid antagonists with a level 1A, and also for SGLT2 inhibitors, specifically dapagliflozin and empagliflozin, to reduce hospitalizations and death. And with one large randomized trial with sacubitril/valsartan, we have level 1B evidence. So we know what works. We know what keeps people alive, and we know what keeps people well in our communities. And we've known a lot of this for a while, but we've got new information in the last few years with a new class of medications, the SGLT2 inhibitors, which we'll talk a little bit about as the talk progresses. So sacubitril/valsartan, if I go back to Tony was changed to that from his ARB, and that was on the basis of this trial, the trial that we're all familiar with. It's this presented about 10 years ago now, I believe, and it's sacubitril/valsartan changes the trajectory of people with heart failure, class 2, class 4 symptoms, reduced ejection fraction, keeps them living well in our communities, 20% reduction in the risk of cardiovascular death. And remember, this trial went head-to-head with an ACE inhibitor, enalapril, not a placebo. 21% reduction in heart failure hospitalizations. People felt better. So again, highly effective treatment at keeping people well in the community and improving prognosis with heart failure, reduced ejection fraction. So when I saw Tony, I recommended we up-titrate the dose of his sacubitril/valsartan. Remember, he started the low dose, 50 milligrams BD. And if tolerated and renal function remained well, we up-titrated his bisoprolol as well to 2.5 milligrams daily, and considered the addition of spironolactone 2 weeks. In 2 weeks' time of up-titration of Entresto was tolerated and renal function remained stable, with a planned review with me in 4 weeks' time. So again, why do we recommend spironolactone? Getting back to the guidelines, these were the guidelines in 2016 from the ESC, and they recommended, so a change from 2016 to the 2021 guidelines. In 2016, they recommended the use of an MRA only in patients who remain symptomatic, despite treatment with an ACE inhibitor and a beta blocker. And that's because there is a significant reduction in mortality, 50 to 60% reduction with combination therapy. That is reflected in the new recommendation from 2021 guidelines that in the presence of heart failure, reduced ejection fraction, regardless of someone, whether they're symptomatic or not, we're recommending getting on and commencing an MRA in addition to an ACE inhibitor, an ARB, and a beta blocker to reduce hospitalizations and death. Again, we still have to apply for special authority for eplerenone as an alternative to spironolactone, but we're all familiar now that there is an alternative available to us in New Zealand for heart failure, reduced ejection fraction, not for other indications for spironolactone, specifically hypertension. So patients need to be intolerant or have side effects, and one of the commoner side effects that we see is gynecomastia in males. The dosing for eplerenone is similar to spironolactone, 25 milligrams a day, so it's easy to remember in that regard. I think with spironolactone, and I use this slide time and time again. I've used it for a number of years, and it doesn't apply just to spironolactone. It applies to all the treatments that we use and should use. I think it's really important we explain expected benefits, that the treatment is given to improve symptoms and to increase survival, that the symptoms improve with spironolactone. Oops, I'll just go back. I don't know what's happened there. Symptoms improve over a few weeks to a few months, and it's important to advise people, and I think this is a really important one. If you get another illness that you're going to lose lots of fluids, such as a GI upset, temporarily to stop spironolactone, as it can impact on renal function significantly quite quickly. So empowering patients to have a holiday from spironolactone if there's other things going on before they manage to catch up with you or I. So getting back to Tony, saw him in May 23. I'd been away. His symptoms were unchanged. He had no escalation in therapy since we last saw him. His blood pressure, if anything, was a little bit better at 130/82. We increased his sacubitril/valsartan to 100 milligrams BD and reviewed him in the hospital cardiology nurse practitioner clinic a couple of weeks later. We're now 3 months post his admission with acute decompensated heart failure. We commenced spironolactone initially 12.5 milligrams daily, and if with the plan of tolerated and renal function stable, to up titrate to 25 milligrams daily. At that stage, we felt confident to stop his furosemide, as we didn't feel there were any symptoms of congestion or signs of congestion. We planned to review him 4 weeks later with repeat renal function and consider the addition of an SGLT2 inhibitor at that time point if renal function remains stable. And that's his list of medications on the right-hand side. You can see he's up to maximal dose Entresto, a small dose of bisoprolol, and the furosemide we have stopped and started spironolactone. So again, getting back to the 2021 guidelines and evidence-based care, why have we recommended empagliflozin? We mentioned earlier level 1A evidence that it reduces heart failure hospitalizations and death in patients with heart failure reduced ejection fraction. These are the 2 pivotal trials, EMPEROR reduced and DAPA-HF, just over 8,000 patients randomized in the trials. And as you can see, mortality benefit, all-cause death, and cardiovascular death, but significantly a reduction in heart failure hospitalizations of around 25%, and cardiovascular combined endpoint of heart failure hospitalizations, cardiovascular death about 25%. And you're as familiar as I am with the data around SGLT2 inhibitors and slowing progression of renal disease. I think that's a really important, action of these medications. So if we look at that meta-analysis of those 2 trials, specifically in patients with heart failure reduced ejection fraction, we saw benefit in patients with or without diabetes, in men and women, in younger and older patients, in the presence or absence of baseline ARNI use, and regardless of baseline health status. It talks not about heart failure preserved ejection fraction, but we now have trials across that heart failure phenotype telling us that these agents impact significantly with a consistent reduction in heart failure, and reduction in heart failure hospitalizations, whether it's DAPA or EMPA, in patients with heart failure reduced ejection fraction or heart failure preserved ejection fraction. So back to our case, we're now 4 months post-admission with acute decompensated heart failure. Current medications are as listed on spironolactone 12.5, it hasn't been increased. Tony elected to self-fund empagliflozin at 10 milligrams per day. And he was organized for repeat echo with subsequent clinic review in 2 months. So we're now 6 months post his index admission with acute decompensated heart failure. That's his medications as shown there. He stopped his empagliflozin the day after his echo. He felt better, but still easily fatigued. His blood pressure is as shown there. eGFR is stable. His natriuretic peptide, and that's an NT-proBNP, I apologize for that. It's down significantly from when I first caught up with him in April. Remember, it was around 600. His ejection fraction hasn't really changed, though, at 30 to 35%. So questions, I've used this case to illustrate, I mean, that would have been our journey with heart failure, and it still is a journey for a lot of patients in New Zealand with heart failure in 2024, but certainly in 2023, 2022, that would be the usual journey of patients with heart failure, with these interactions with healthcare professionals at variable time intervals over a prolonged period, with changes recommended and made in medications. So how could we have done better for Tony in Tirafety? And there are two of my colleagues, physician colleagues in Tirafety. There's a bucket there with a leak in the roof that Chris and Alyssa are standing beside. But could we have actually done things differently? Would a longer initial hospital stay have led to him going home on more evidence-based care? His hospital stay when he was in the first time was around 3 days. Could we have transferred his care better to primary care with a clear action plan of what to do when he was discharged from hospital? Would a cardiology model of care resulted in better care for Tony when he was in hospital? In Tirafety, that would be incredibly challenging. What's the role of physicians in heart failure management in 2023, 2024? We're now in. Should physicians have more expertise in heart failure management? There's been lots of changes in heart failure management over the last 12 to 24 months. And what's the role of other healthcare professionals? Could they have helped? For example, could we have used pharmacists to help up titrate medications, healthcare assistants to obtain blood pressure measurements, organize for bloods, etc., in the community that may have helped us in our decision making with Tony. So we go back. So we towards the end of last year, we published a statement in the New Zealand Medical Journal. In fact, it was published this year on our thoughts on improving management of heart failure in New Zealand. Three key points in this, and one of them is improved access to evidence-based pharmacotherapy for patients with heart failure. Secondly was the importance of early initiation and titration of pharmacotherapy. And the third is the workforce required to ensure optimal outcomes for patients with heart failure. I'm not going to talk about the workforce. We could just be consumed with that for the next hour and the challenges of workforce, but there's a lot of people trying to work to improve our workforce, not just recruit, but retain our health workforce in New Zealand. You're all aware that with a lot of advocacy over the last 2 to 3 years, 3 years really, we started this journey. Pharmac have proposed access to empagliflozin for chronic heart failure. That's a proposed criteria shown there for patients with heart failure, patients who remain symptomatic with NYHA class 2, 3, or 4 symptoms, with documented left ventricular ejection, reduction in left ventricular ejection fraction, or where an echo is not reasonably practical for access issues, again, that we're all very familiar with, and that the patient is receiving concomitant optimal standard chronic heart failure treatment. So that means practical purposes, an ACE inhibitor or an ARB, allosterone antagonist, and a beta blocker. This falls short of what we wrote to Pharmac at the end of last year, updating Pharmac with the evidence that, and the guidelines from the ESC that recommend an SGLT2 inhibitor also as first-line therapy for patients with heart failure preserved ejection fraction. So that new evidence has not been considered in this proposed special authority for subsidy that is restricted to heart failure reduced ejection fraction. So we are anticipating that empagliflozin will be available to us by the end of the year or early next year, and that is good news. We've still got work to do because there's still a lot of people who will benefit from heart failure from empagliflozin with heart failure preserved ejection fraction, and we need to continue our work to try to get access to that for patients with heart failure preserved ejection fraction. So the importance of early initiation and titration of pharmacotherapy, and we know a lot more about this in 2024 than we did 2 years ago. And the strong heart failure group have led the charge with this. And this is a pivotal trial. I'll just take you through this. It is worth just going through this in a little bit of detail. So this was performed in 87 hospitals in 14 countries, predominantly in Europe. Patients, the age range is shown there, 18 to 85. And patients, inclusion criteria were patients with acute heart failure ready to be discharged. Okay. And a very high BNP, NT-proBNP post-discharge. Patients were randomized to either high intensity care or usual care. And the high intensity group, the plan was to have them going home and half optimal guideline-directed medical therapy. So at that stage, what was guideline-directed medical therapy? When the trial was conducted, there were very few patients on an SGLT2 inhibitor. I think around 5% of patients. It was coming into guideline-directed medical therapy as the trial was being conducted towards the end of the trial. So for the vast majority of patients, this meant triple therapy. ACE inhibitor, ARB, or sacubitril/valsartan, aldosterone antagonist, and a beta blocker. The intent of the strong investigators was to up-titrate, so patients in the high-intensity arm went home at half-optimal therapy. The intent was to get them up to full optimal therapy within 2 weeks, full dose optimal therapy within 2 weeks. And they were able to achieve that in 80% of patients. And follow-up was 90 days with primary endpoint, 180 days, heart failure readmission or all-cause mortality. And as you can see here, there was a significant reduction in patients randomized to the high-intensity care group versus usual care. 34% relative risk reduction, 8% absolute risk reduction in the combined primary endpoint. 44% reduction in heart failure readmission alone, 16% reduction in death. Important also, and probably doesn't show itself well in this graph, but the curves started to diverge quite early. So by about 40 days, these curves were starting to diverge. So emphasizing the importance of getting on and doing this sooner rather than later. Some newer data from the strong HF group suggests that the higher we can get the doses, the better our patients will be in the longer term. So again, looking at all-cause mortality or heart failure readmission through to day 180, where the primary endpoint was, that patients where you were able to get the dose up to greater than 90% as a mean of the 3 drug doses, they had the best outcomes. So emphasizing the importance of getting on and maximizing doses. So on the basis of the strong HF trial, and also the data that we had around the benefits of SGLT2 inhibitors in patients with heart failure preserved ejection fraction, the ESC added an adjunct to the 2021 guidelines last year, so a limited revision of the 2021 guidelines. And this is what the ESC recommend around pre-discharge and early post-discharge care of patients hospitalized for acute heart failure. So an intensive strategy of initiation and rapid up titration of evidence-based care before discharge, careful follow-up visits in the first 6 weeks with the intent of maximizing therapy. Again, emphasize strong HF, ACE inhibitors, ARBs, ARNIs, beta blockers and MRAs. Very few patients were on empagliflozin or dapagliflozin, some, but not a lot. 1B, why is it 1B? There's one randomized trial telling us and informing the guidelines, but an important trial. What are the things that we should look for in follow-up of patients? Symptoms and signs of congestion. I stress congestion time and time again. It's really important. That will make our patients feel better. Blood pressure, and it's not just a number. It's whether someone is symptomatic with a blood pressure that you or I might think is a little bit low, and we're a bit hesitant to increase the medications. Do they have symptoms of postural hypotension? Heart rate's really important, and heart rate sometimes, heart rate is a sign of congestion, and congestion that we're not treating well. So just pay attention to the heart rate. The natriuretic peptides are important adjuncts to helping us optimize care, both pre-discharge and in the community. And of course, it's really important when we're looking at these medications that all can impact on renal function. What's the potassium status and what's the eGFR? Despite what we've known and have known for a while, the use of optimal guideline-directed medical therapy is low. And this is from one of the registries in the United States. And if you look here, proportion eligible for quadruple therapy, 82% of patients admitted with acute decompensated heart failure, and the Get With the Guidelines project in the United States, program in the United States, only 15% were discharged on quadruple therapy and 40% on triple therapy. This is impacting adversely on our patients' lives, and this is some estimates from the benefit of quadruple therapy in 2024. We add 8.3 additional years free from cardiovascular death or hospital admission for heart failure to our patients, with up to a 61% reduction in all-cause mortality versus conventional therapy. So powerful medicine. What are the barriers? There's lots of barriers. Things that you and I do or don't do, lack of awareness of the benefits, focus on treating symptoms, not what the longer term outcomes are. The fear of adverse effects. We talked about blood pressure. Patients, we are a little bit more hesitant around up-titrating medications in older patients. And some patients are intolerant of medications. There may be some contraindications. And of course, some of these treatments, certainly in our own country, we've had limited access to treatment, which hopefully is about to change in the not too distant future, at least for 50% of our patients with heart failure. We had a look at this in Terafity last year over patients admitted with acute decompensated heart failure. And what are we doing? And this is August 2023, and we looked at 30 days and 6 months. And as you can see here, I'll look at the last two columns over here. Patients were discharged. 1 in 3 patients were discharged on 3 classes. If you add 4 classes in, then 50% are discharged in either 3 or 4 classes of evidence-based care. But not a lot happens when we follow these people up in the outpatients. So we've all got room to improve in our management of patients with who present with acute decompensated heart failure. How might we do this differently? And we, with others around the country, and a lot of this work has been led by Rob Doughty and Melinda Copley in the Auckland region, looking at heart failure, rapid up titration, and a lot of us are learning from each other how we do this and do it better. And so this is one of the schematics for how Auckland are doing this. They are screening for patients in hospital, and their aim is to have patients with heart failure reduced ejection fraction on low dose of the 3 to 4 pillars, review them early in clinic, and then over a 6-week period, remember, Strong tried to optimize patients within 2 weeks. We believe in our health system that's going to be hugely challenging. So the stretch target out to 6 weeks, and they are using their heart failure nurses to lead this program with support from the SMOs. Again, emphasizing the things that we look out for: symptoms and signs of congestion, heart rate, blood pressure, renal function, and natriuretic peptide. And the goal is to have patients on maximally tolerated doses within 4 weeks. And this is an exemplar that Rob and the team have shared with us. A 56-year-old man admitted with a new diagnosis of heart failure. It's non-ischemic. His ejection fraction 24%. Discharged on low dose with note he's on 80 milligrams of furosemide. By 4 weeks, they have discontinued his furosemide, and he is on good doses of Entresto, bisoprolol, spironolactone, and empagliflozin. He is self-funding empagliflozin, and he is taking half a 25 milligram tablet, as opposed to the 10 milligram tablet that was used in the heart failure trials. And at 10 weeks, his ejection fraction has improved to 48%, and his RV function is back to normal as well. So our experience with this is early in teraphy, and this is a patient who we've gone through our program recently. 58-year-old man with acute decompensated heart failure, nothing of note in his past history, prior heavy alcohol intake with an MCV of 104. He'd stopped a couple of months before. Chest X-ray, I probably can't say it that well, but there's evidence of upper lobe redistribution and small pleural effusions in both sides with cardiomegaly. Sorry, I just have a... So his creatinine, eGFR were normal. His natriuretic peptide was elevated. His troponin was up, but there was no rise or fall. And the echo showed features that we felt was consistent with a dilated cardiomyopathy, unlikely to be an ischemic origin, but he's awaiting a CT as an outpatient. So he was referred to our heart failure rapid up titration clinic, and these are the aims as shown here. So firstly, to identify newly diagnosed heart failure patients suitable for rapid up titration. So our expectation is if people are referred to our heart failure service for rapid up titration is that they're screened. You probably can't read that well, but the inclusion criteria is heart failure, reduced ejection fraction, a reasonable systolic blood pressure, reasonable renal function with an eGFR greater than 30, potassium less than 5.5. They have not been in IV vasodilators or anatropes within the last 24 to 36 hours, and clinically they're not frail. So this is for the rapid up titration program. So if someone is eligible, we would hope that they are started on low dose of the 4 pillars of medications pre-discharge, and the referral form is completed to our service. So this man was on diuretic, he was commenced on bisoprolol, he was commenced on sacubitril/valsartan, and elected to self-fund empagliflozin and discharged on the 12th and the 9th. He was not commenced on an aldosterone antagonist. So again, referred, and then through the up titration clinic. And that's a combination of tele consultations and face-to-face consultations currently. I'll just skip that for the moment. I can come back to that if need be. Clinic follow-up at the end of last month. His symptoms had improved. His blood pressure was satisfactory with no postural drop. His renal function was stable. His sacubitril/valsartan was up titrated, and he commenced spironolactone with the intent to do a BNP and a follow-up echo in, I think, 3 to 4 weeks' time. So our differences in New Zealand compared to strong HF is that we look at we're looking currently at we believe two weeks is not, it's not going to happen in New Zealand. We're looking at 6-week time frame to try to get people on maximal therapy. We still have limited access to sacubitril/valsartan. That's not changed currently. We hope to have increased use of SGLT2 inhibitors in the not too distant future, less diuretic use, which will result in less diuretic use. Remember, SGLT2 inhibitors are a diuretic as well, and they augment diuresis. So that's something to bear in mind when you're using SGLT2 inhibitors. And this is real world. And we've got, you know, I'll give you an example of a remote location with titrated. Might well say, well, that's all very well. That's patients who present with acute decompensated heart failure in the hospital. What about patients with stable heart failure referred to a general cardiology practice, or who you look after in your practice? And this trial presented at, it's not been published yet, it presented at the heart failure meeting in Europe earlier in the year. So patients referred to the guideline-directed medical clinic from a general cardiology practice with symptomatic heart failure and ejection fraction less than 50. So basically a combination of telemedicine and titration clinics. And what you see here, the numbers are very, very small, so you're not going to see a difference in clinical outcomes here. What they did see was changes when they looked at LV function on echo and some of the other parameters that we look at as markers of heart failure, cardiac dysfunction on echo. But what they were able to do with this approach, they were able to maximize therapy. So again, it works in a setting, in an outpatient setting for a different group of patients as well. So again, to finish, the patient's journey with heart failure continues to change. You know, our model previously has been someone gets admitted with acute heart failure, they get treated with diuretics in hospital. We try and start some evidence-based care to improve prognosis in hospital, but do the majority of that work in outpatients. I think there's been a paradigm shift to trying to get on, and evidence-based shift to getting on and starting medications, low doses of pillars of care that improve prognosis whilst in hospital, and maximizing that in an outpatient setting over a 6-week period in New Zealand. I think it's really important that these are the things that we should consider when we're seeing our patients with heart failure at every time point, really. Evidence of congestion, what's the blood pressure, what's the heart rate, what's the renal function, and using BNP to aid optimization of care. So to finish, on Monday, when we all go back to, tomorrow, when we all go back to our practices, are my patients with heart failure on optimal evidence-based care? Is this reflected in their well-being clinically and what their biomarkers tell us? Does this currently include aldosterone antagonists and consideration of sacubitril/valsartan? Whilst we await for special authority for empagliflozin, which we believe is not too far away, I think it's important that we do offer patients the opportunity to self-fund. And our patients with heart failure, remember there's a population of patients who you and I look after with heart failure and type 2 diabetes. Are they eligible on HbA1c criteria for an SGLT2 inhibitor? So I'll stop there and take some questions. And I think we're pretty much on time, I think, are we?
I think we're doing very well for time, Gerry. Thank you. But plenty of questions have been flowing through during your presentation. So I'll try to group them as much as possible. So yeah, I think if we just kind of start talking a little bit about that immediate post-discharge phase, and just want to clarify for all our speakers, when we're talking about those 4 pillars, we're talking about an ACE, ARB, or ARNI as 1. We're talking about beta blocker as 2. We're talking about spironolactone as 3, plus SGLT inhibitors if they can self-fund, if assuming they're not, say, they've already got type 2 diabetes. Those are our 4 pillars that they can all be started on at the same time if they're not already, and they can be discharged on that. Just to clarify for all our viewers.
Yes, absolutely. Yeah.
And if they were to still be congested, as you mentioned, quite a lot of our patients may be congested still at discharge, we could have furosemide on board as well at the time of discharge, with the long-term goal being that if we've optimized the 4 pillars, they won't need furosemide or other loop diuretics in the long term.
Yeah. And it's an important question, isn't it? Because often we feel uncomfortable stopping the diuretic. We feel, you know, it's been started in the hospital. Most people, you know, with acute decompensated, the vast majority of people with acute decompensated heart failure will come out of hospital on a loop diuretic. Very few people will not be on a loop diuretic. But it is worth reminding us all that it is something that we should consider is it needed? Is there evidence of congestion? Is it actually being a hindrance to us optimizing other medications? So is it stopping you up titrating the dose of sacubitril valsartan in someone who's decongested? We've got no evidence of congestion. And I think it's important that we are brave enough to ask those questions.
And a question that someone had around how long you can keep someone on both a furosemide and other diuretics. Obviously, you know, your SGLT diuretics, your spironolactone's a diuretic as well. Do you have any thoughts on, is it safe? I know obviously you mentioned about the increased mortality, but is it safe for them to be on it long term?
Yeah, well, we often have people on doses of diuretics for a long, long time because they need it for symptoms. I mean, it is interesting, isn't it? Is there any prognostic benefit from a diuretic? Is there any prognostic benefit from a loop diuretic? Trials have never been done, but they've always been background therapy in all the trials that have been done of acute decompensated heart failure. We don't believe that there is. So there, you know, how I look at loop diuretics, thiazide diuretics, well, because again, we sometimes add them in, don't we, as well? It's to manage symptoms of heart failure. But at the same time, whilst we push up the other medications that will impact on outcomes and hospitalizations and keep people living well in the community.
And then another follow-up question around in that kind of post-discharge congested phase. While they're still congested, do you want to focus on diuresing them before you start up titrating those 4 pillars, or is it safe to start up titrating while they're still congested?
It's safe to up titrate. It's safe to up titrate, and that's the point that I think, you know, that has actually changed. That we're getting on and doing that now, and we should be getting on and doing that in hospital. Go way back. I'm old enough to remember beta blockers and heart. You know, when we, Rob Dowdy did some of the pivotal from Auckland, did some of the pivotal work on beta blockers in heart failure. You know, we changed that paradigm. You know, we were all terrified of giving beta blockers in heart failure. In fact, it was contraindicated to get beta blockers in heart failure until the trials were done. So I think it's really important that we get on, and someone comes in through the front door with bad heart failure. Yes, diurese them, but get on and do the other things as well. The bit that I'd be a bit more wary about is beta blocker is probably the one, if someone's got a persistent tachycardia, that might be a sign of congestion. You might want to do some of the other things first, get them on an RNA, get them on empagliflozin is probably one of the, if we had it available to us and we were able to use it, and I think some of the units overseas, they get that in quite early now, because you get that augmented diuresis and you get the prognostic benefit as well.
So as you were mentioning, kind of in terms of the post-discharge rapid up titration phase, we're kind of talking maybe 6 weeks with regular check-ins. You talk specifically about if we're talking about lab testing, particularly monitoring potassium, renal function, and BNP. There were a few questions on how often you think those should be checked.
Yeah. So I think that is important. That is the strong HF. That's their guidance that they put in around, how they recommend one considers, and I'd say one considers, and I think it's horses for courses as well, but this is a suggested schematic, really, or an algorithm for how you might decide what to do with your medications. So around what do you check when you check it, I think renal function is probably it is the most important one to actually check and make sure is stable. I know the group, Rob and the group in Auckland, they tend to check renal function at every visit. And I think that's probably that's ideal, really. During that 6-week phase while you're getting people up to maximal therapy, I think it's really important. It's a safety point. Do you need to check NT-proBNP at every time point during that 6-week period, particularly if you're seeing patients every week? I'm not certain about that. I think you certainly need a BNP at the beginning and you need a BNP at the end. And also, if you've got any concerns about this isn't quite right, I'm a bit hesitant about up titrating. I think that's when I would do a BNP as well.
Sure. And I think your slide kind of answers, there were a few questions around blood pressure as well. Obviously, you mentioned about, if someone's asymptomatic with the lowish blood pressure, you'd still probably push on. But
I would be, you might be a bit more cautious, but I would push on.
Yeah, there
And
was
I
a
think
question.
that's really important because I didn't emphasize that enough in the presentation. I mean, strong HF, it also emphasized to us that it's safe to up titrate aggressively. So it is safe. It's not just as a benefit, it's also it's safe to do it. So it should reassure us. We've got evidence-based care telling us that it's safe to up titrate quickly, even in the elderly.
Right, yeah. However, I think noticing on your slide it says pause if it's less than 95. So if we're in the 90s with the systolic BP, you might be a bit more cautious, or would you?
Absolutely,
Yeah.
absolutely. Yep, yeah,
I think people were just some of the viewers just wanting some guidance. We always like to have some hard numbers in the back of our minds,
yeah,
yeah.
yeah.
Yeah. And it's interesting you kind of mentioned the elderly because one question was around Entresto, and is there any age that you would not consider Entresto? And this viewer was saying they don't see a lot of patients in residential aged care, which I'm assuming they work with, not getting Entresto. Any thoughts you have on age and Entresto or any of the other pillars?
I mean, I think we need to treat patients appropriately. We need to treat. I mean, there is no evidence that our elderly New Zealanders don't benefit from treatment for heart failure. In fact, if you go back, there is some evidence. I'll go back to ACE inhibitors, ARBs. There is strong evidence, registry evidence. I know it's registry, but there's evidence to suggest that they do benefit as well from ACE inhibitors, ARB. So I don't think we should be not denying patients access to evidence-based care in the base of age. I think we need to look at what else is going on for that patient in front of us. All the other comorbidities, not just age.
And moving on to just spironolactone, there was just a question, as you mentioned, kind of gynecomastia is one of the common side effects. Are we talking more around, I guess, if someone has personal concerns around cosmesis, or are there any other concerns? I mean, are you aware of any issues with breast cancer risk, I guess, if
Yeah. My understanding that there is an increased risk of breast cancer if you develop gynecomastia with spironolactone. The other thing is it is meant to be reversible, but some people that it's not reversible. So I think certainly if you get gynecomastia, I think it is an important side effect that I think we have an alternative available. I know it's a pain. I know we've got to apply for it, but it's available to us.
Sure.
And it's easy to use. It's the same dose. It's exactly the same dose with the same things that we monitor, renal function.
And on the topic of special authorities, plenty of questions on empagliflozin. Any thoughts you have about giving empagliflozin in type 1 diabetes with congestive heart failure? I had a quick look at NZF and they're saying it's a no-no because of the risk of DKA.
Yeah. So I would be guided by them.
Yes.
Yeah.
Sure, yeah. And do we know where we're at with Pharmac actually in the timeline? I'm sorry if I missed that while I was looking through the questions with funding for.
Yeah. So my understanding is that we should know by the end of next month or early next month where we are with an expectation of funding availability, probably before the end of the year or early next year. Lots of us have fed back that we welcome it. It's long overdue. A little bit disappointed that it doesn't cover the entire phenotype of heart failure, preserved ejection fraction. We've now got really strong evidence of the benefit there. In fact, we've got no other treatment options in that population. So we're disappointed about that. But let's get this up. Let's get it for this indication and continue to advocate and lobby for better access for heart failure, preserved ejection fraction.
And can you comment on optimal dosing for empagliflozin for congestive heart failure?
10 milligrams a day. There is no benefit with escalating to 20 milligrams a day.
Okay.
I didn't talk about any of the side effects with empagliflozin. I mean, you mentioned DKA. I think in the heart failure trials that was incredibly uncommon. It's the side effects better than I do. You guys use this. You've had more experience with it than cardiologists thus far. But it's the glycosuria is the big one that leads to increased fungal infections, and I think that's education, isn't it? Yeah.
It's interesting because I think one of your study cases, they were on 12.5 milligrams of MPEG, if I
Yeah, so the rate you missed. Yeah. So the reason that's the 25 milligram tablet. They're self-funding. They've cut it in half, and they're getting, it's stretching further.
So
They're
it's
getting
not necessarily a safety thing, it's more
no,
it's just no benefit beyond 10.
no, not at all, not at all. No, the doses in the heart failure trials 10 milligrams.
Sure. Are you aware of what the rough price is at the moment for patient
I
self-funding?
I don't. I knew you were going to ask that, but I don't.
I think I did a bit of sly Googling during the talk, and I saw something say $58. If anyone wants to correct me on that, please do. However, another viewer did mention that some of their patients are getting MPEG funded through work and income or MSD.
Yes, and we've certainly done that for patients. We've advocated and used that pathway for some of our patients in Terafity. But I think it's really important. We shouldn't assume that someone won't pay for it. I think that's a really, common thing at times for, health professions. We just, we need to give patients the opportunity to self-fund. Hopefully this conversation's, no longer an issue come December, January.
There was another question just around your thoughts around more basic stuff, just fluid restriction. Does that still fit with 4 pillars of care? Is that changing at all? Your thoughts there?
Well, it's not something that we would, it's more salt when someone comes in with acute decompensated heart failure that we've done historically. Now that's got a little bit more muddied as well, with a trial telling us that it probably doesn't do any benefit salt restricting people who come in with acute decompensated heart failure. I think it depends on the severity of the heart failure. If you've got someone who you're struggling with chronic heart failure, then I think looking at salt and fluid restriction, they go hand in hand, don't they? That might actually be an adjunct to managing that patient's, in the chronic, when they're in the community, to try to keep them well in the community. But it's not something we tend to recommend as much as we would have done 10 years ago.
And now just to clarify the proposals you had for the rapid titration clinics, they're very much in the planning phase, because one person was asking, is this something that you would suggest even patients who are diagnosed with heart failure in the community, not necessarily admitted with acute heart failure? Is there some benefit for those patients as well, rather than just in that post-discharge follow-up and
Yeah, well, that trial that I mentioned at the end, it's one of the first trials I've seen addressing that population, and they were looking at the mechanisms of why that might actually be beneficial. So they saw changes in the degree of mitral regurgitation, for example, in someone who had impaired LV function. But it shows it's possible. It shows it's safe. And there's no reason why we shouldn't be doing it. And we're actually starting to do a little bit in Terafity. How have we been successful with our program? We've managed after 2 years to get one FTE nurse, 2 people appointed to help us with this program. And they're supervised by 2 of our cardiology nurse practitioners when I'm not there, with me there as a resource. And we try to catch up once a week to discuss patients either remotely or when I'm physically on site. So our model's different again, but it's how we do this differently. And I mentioned earlier, certainly for the patients in the community, I think that primary care need to be involved with this all along, but it's how we then look at how can we involve pharmacists. There is a paper that I didn't show the slide on tonight from the UK, where they use pharmacists to actually up-titrate, pharmacy prescribers to help up-titrate patients. And they did it as well as any of us. We laughed at the beginning. I think you and I were having a chat. Taking doctors out of it is actually is a really good thing, because we do not do protocols as well as, other health professionals.
There was another question. Do you have any specific advice for patients with markedly reduced renal function to begin with, like eGFR less than 30? Is that how does
Really difficult group of patients, really difficult group of patients. I mean, the data around sacubital valsartan, for example, there is no data. EGFR less, certainly EGFR less than 20. The I think EGFR patients less than with an EGFR less than 20 were or 30 were excluded from the heart failure SGLT2 trials as well. So really difficult, and a lot of it is symptomatic management with using an ACE inhibitor, ARB, and a beta blocker as the medications that we probably, well, we've got a little bit more knowledge. We've been using them for a lot longer.
There was just a question just wanting to clarify how we use BNP, and I guess appreciating that might be easier to access via labs in certain parts of the country versus others. So could you just for everyone's benefit, just kind of give a bit of overview of how we would use BNP as we're titrating and monitoring?
Yeah, it's a really good question. And so BNP, I mean, BNP, the history of BNP in New Zealand is, a lot of the pivotal work for BNP and heart failure was done by the Christchurch group. So it's informed international guidelines. So where BNP really is extremely helpful is diagnosis or exclusion, particularly the exclusion of someone who you or I think might have heart failure. So if you've got someone in front of you and they're diuretic naive and their BNP is normal, the likelihood of that patient having symptomatic heart failure is extremely low. So it's really good test to exclude heart failure. How do we use it to help optimize care? I think as you know, there's a lot of variables that influence BNP as we get older. So age affects it. The presence of high blood pressure, atrial fibrillation, renal failure can put BNP up. So does BNP help to optimize care in all patients? The answer is probably better in patients under the age of 75. We've got stronger evidence base to suggest that it might be helpful. But certainly if you've got someone in front of you that you're struggling, particularly with this rapid titration pathway, we want to see their BNP coming down. If their BNP is not coming down, that suggests there might be a bit more congestion still there. So you might want to look, if you haven't already started EMPA, get on and start EMPA, or you might be a bit hesitant about stopping your diuretic to up-titrate other things. Yeah. So BNP, I guess we've had BNP around in New Zealand for quite a long time, and it helped. I think we're all still learning how to use it. But I think it is a remarkably helpful tool in our management, in our diagnosis and management of patients with heart failure, particularly to optimize care.
And I think another follow-up question, I guess, again, getting to access around imaging, it's easier said than done to get access to an echo, even in secondary care in some parts of the country. And so for, I guess, those of our colleagues working in primary care who are not able to get access and kind of confirm if there is preserved ejection fraction or not, what advice do you have in terms of employing some of these pillars? And maybe it might be hard even getting special authority, for example, because I think there was some sort of, if I remember kind of briefly the slide you had for the proposed special authority for
if you can't get an echo, just get on and you think someone's got and that in some ways that's actually a really, so if you've got a BNP that's elevated, you've got someone who you believe's got symptomatic heart failure and you can't get an echo, then you should be getting on and starting evidence-based care that includes empagliflozin once we have it available to us. We didn't talk anything about heart failure preserved ejection fraction, but we believe that there is a benefit of some of the other evidence-based treatments that we talked about, but possibly not to the same degree. So aldosterone antagonist, sacubital valsartan, it's attenuated. So you're not going to harm patients by getting on and starting those medications while you're waiting for an echo. So I think assuming that they've got normal renal function. So if you've got that patient, you can't get on and again with the same special authority caveat for starting Entresto, if you can't get an echo, then you haven't been able to get an echo. You've got the ability to start Entresto as well. So getting on and looking at evidence-based care whilst you're waiting on a diuretic for symptoms, whilst you're waiting for assessment, seen by cardiology or an echo. Take your point about access to echo. It's a real issue up and down the country.
And another interesting question, do you have anything to comment about iron infusions or their role in heart failure? And
yeah. Well, heart failure reduced ejection fraction, it makes people feel better. Whether the impact on mortality is questionable, but it probably impacts on reduction hospitalizations as well. But it's specific for heart failure, reduced ejection fraction. That's my understanding of where we are with the data currently.
And I guess just to do a plug for the talk you did, I think 3 or 4 months ago, you said, Gerry, on preserved ejection fraction that you did for the Goodfellow unit. So if anyone has any follow-up questions about that, you can access the recording of that webinar through the website. I'll just mention there was some advice from one of our viewers. Empagliflozin is approximately $80 for a 10 milligram tablet and approximately $40 to $45 for a 12.5 milligrams. So I'm assuming if you have the tablet there, so I think that'll be good for them to know that. There were a few questions actually just around genitourinary symptoms, which we know is a common issue with empagliflozin. Any comments you have to say about managing that, or in your experience? So, as you said, we may well have in primary care.
You've got much more experience than we would have with that. We would just advise about hygiene. Really, that's probably the big thing, isn't it? It's a big thing. I see a question there from Andy McLaughlin. Andy is a heart failure nurse practitioner in the Auckland region, and he's saying we should empower people to understand signs of congestion, use of diuretics only when needed. And I couldn't agree more, Andy. Couldn't agree more.
Well, I think with that, I think we will wrap up. So I just want to extend a very big thank you to Gerry for your excellent talk tonight. And I think it obviously got a lot of people motivated and thinking, because we had plenty of questions. So I had a good question and answer back and forth. So yeah, again, thank you very much for everyone's attendance, and we look forward to seeing you at the next webinar. Thank you so much.